Hello, I'm Rachel Lawson. I'm a psychologist at the Translational and Clinical Research Institute at Newcastle University, and I'm going to talk to you today about identifying delirium in patients with Parkinson's disease. Before I start, I'd like to tell you about one of my patients, who we'll call Grace. Grace is a lady in her 80s. She's had Parkinson's disease for over 10 years, and I've known her for almost as long. And she was admitted last year to hospital following a fall. When I saw Grace, she was confused and had difficulty maintaining a conversation. She didn't know where she was. She thought that the staff there were keeping her against her will and wouldn't let her go. She saw snakes around the room and were talking to people who weren't there. And at night time, the staff reported that she had difficulty sleeping and was trying to get out of bed. Now, you might wonder if this patient had dementia associated with Parkinson's disease, but Grace had a delirium. And unfortunately, delirium isn't always identified in people with Parkinson's disease, and that's because of an overlap in symptoms. Many of you will know that Parkinson's disease is a movement disorder. And when you think about Parkinson's, you might think about a tremor or people with walking difficulties or problems with falls. But what you might be less familiar with are the non-motor features. These are symptoms like fluctuating attention, sleep disturbances, excessive daytime sleepiness, hallucinations and delusions. These can be red flags for delirium, but if people with Parkinson's present with these symptoms in hospital, it can sometimes be assumed that it's part of their Parkinson's disease and delirium might not be identified. In Grace's case, the symptoms she had in hospital were out of the ordinary for her, but she did have a delirium. And she did have also a history of mild cognitive impairment with some impairment in attention and had previously reported complex hallucinations. So how do we tell if somebody with Parkinson's has delirium? A brief search of the literature didn't really tell me very much. So with some colleagues, we did a systematic review and only found 20 studies that looked at delirium in people with Parkinson's, and the quality of these studies were very varied. The first question I wanted to ask was, how common was delirium in people with Parkinson's? The prevalence ranged widely from 0.3 to 60%. Looking at inpatient studies, prevalence ranged from 22 to 48%, and postoperative delirium occurred in 11 to 60% of participants. Some of the studies also found that having Parkinson's was itself a risk factor for delirium. The second question I wanted to answer was, what criteria or definitions of delirium should we be using? I found that 7 different criteria were used across these studies, but only 5 used the CAM, 2 used the DSM criteria, and 1 used ICD-10. The rest used criteria based on the present specific symptoms such as hallucinations or agitation. The varied criteria used across the studies, I think, partially accounts for the varied prevalence of Parkinson's disease and why we see such a wide range of prevalence reported. However, none of these criteria have been validated in people with Parkinson's. It wasn't clear in many of the studies how the criteria were operationalized or how symptoms associated with Parkinson's were differentiated from acute changes associated with delirium. And this means that potentially delirium could have been misdiagnosed in people with Parkinson's. This is a really serious issue because of the number of poor outcomes associated with delirium in people with Parkinson's. Most seriously, there is an increased risk of death and an 8 times risk of dementia. Worryingly, these risks increase if delirium is not diagnosed. So we felt as though we've identified a gap in our knowledge, and as a first step to try and plug that gap, we developed a pilot study to investigate delirium in inpatients with Parkinson's. We aimed firstly to identify the prevalence and incidence of delirium in people with Parkinson's, and secondly, to look at delirium screening and reporting in hospitals. And this was to help us to design a planned larger study. So we identified all people with Parkinson's who attended Newcastle Movement Disorder Services for the management of their Parkinson's disease and applied an electronic alert to their medical records. This would let us know every time somebody was admitted to hospital over the 4-month recruitment period. We then approached them to invite them to take part in the study, and we had a consultee process for those who lack capacity to give informed consent. Those who consented to take part completed a single delirium assessment as soon as possible after their admission to hospital. This was based on the protocol from Sarah Richardson's DECIDE study, which operationalised the DSM-5 criteria using a standardised assessment and also included a collateral history. Applying this criteria, we found that 34% of the 53 admissions had prevalent delirium when assessed as soon as possible after admission. This is much higher than we might expect compared to age-matched people without Parkinson's. However, a single visit is not enough to identify delirium that might have developed after the single visit. So we also reviewed the medical notes of all participant admissions and applied a validated consensus method described by Kuhn et al. This uses clinical vignettes and applies the DSM-4 criteria to abstract symptoms systematically using verbatim comments and clinical tests or observations. Reviewing the medical notes, we found that only 25% of Parkinson's admissions were screened for delirium by the admitting team, and this identified only 3 cases of probable or possible delirium. This is compared to 34% prevalence we identified using the single visit. However, since the study ended, delirium screening practices in Newcastle hospitals have changed, so we would actually expect this figure to be much higher if we were to repeat this in the future. Applying the Kuhn et al. Method, we identified incident delirium in 57% of admissions, so more than half of inpatients we recruited had delirium during their hospital stay. And this is higher than we might expect in age-matched people without Parkinson's. If we look at the documentation of delirium in patients' medical notes, only 15% had delirium documented, and only 5 people had delirium listed in the discharge summaries to the GP, which we think shows that more work is needed in this area to raise awareness and identify delirium in people with Parkinson's. But if you have a patient who you suspect may have delirium and they have Parkinson's, what could you do? So far, as I've already mentioned, no tests have validated the delirium criteria in people with Parkinson's, but we've looked at which commonly used bedside tests of attention and arousal and symptoms reported by patients and their family members, and which of these may be helpful in helping to identify delirium in people with Parkinson's. So what does delirium look like in people with Parkinson's? Dr. Rachel Cullinan is a psychiatry trainee looking at this data. She has found that over half of people with Parkinson's and delirium had a hypoactive presentation. This means they present as more withdrawn, quiet, and sleepy. This can be overlooked compared to hyperactive delirium, which typically presents as a more heightened arousal where patients can be restless, agitated, or aggressive, for example. But we can see that in some cases, both hyper and hypoactive symptoms can be present, so there's more of a mixed presentation. If we look at the symptoms they present, people with Parkinson's and delirium are more sleepy during the day. Carers reported that they were more confused. More hallucinations were reported, more delusions, and patients were also more distressed. Asking more general questions about their sleep and fluctuating cognition were not significantly associated with delirium, and only a small proportion of participants wondered, which is more typical in hyperactive delirium. However, only a few of these symptoms were reported in the medical notes, with confusion being the most commonly reported symptoms in the medical notes, and we found this was reported in a third of cases. However, this is compared to over 80% of cases with delirium, where from the collateral history, a new confusion was noted. Our master student Daisy Kershaw looked at specific tests of attention and arousal commonly used to test for delirium. She found that asking patients to repeat short strings of numbers, so a digit span forward test, wasn't significantly associated with delirium. However, a backwards digit span and asking patients to repeat the months of the year backwards were significantly associated with delirium. Tests of arousal significantly associated with delirium were the Glasgow Coma Scale, the Observational Level of Arousal, or OSLA, and the Modified Richmond Agitation Scale, or MRAS. We ran a rocket analysis and reported the optimal cutoffs for people with Parkinson's here, and compared the findings to older adults without Parkinson's from the DECIDE study. For most tests, people with Parkinson's and delirium had stricter cutoffs compared to older adults with delirium. So people with Parkinson's had more impaired scores to identify delirium compared to older adults. And we think that this shows an underlying impaired attention and arousal in people with Parkinson's. Therefore, slightly stricter cutoffs are needed to accurately identify delirium in this group. Overall, we found that just doing testing for dysfunction in attention or arousal could help identify delirium with a good level of accuracy. However, tests of both attention and arousal, which is the orange line shown here, has the best accuracy and identified correctly 87% of people with Parkinson's and delirium. And this also had high sensitivity and specificity. However, these results only consider prevalent delirium at the time of admission to hospital, and in the future, we need to consider this longitudinally. So as part of my fellowship, which is the Delirium PD study, this is what I'm going to be looking at, how symptoms change over time and what the best ways are of identifying both prevalent and incident delirium in people with Parkinson's admitted to hospital. So in summary, I'd like to leave you with a couple of key messages. Firstly, that delirium is common in people with Parkinson's and frequent screening is needed. And thinking back to Grace, who I mentioned at the beginning of the talk, it's really important to find out if the symptoms are an acute change. Secondly, simple bedside tests of attention and arousal can help identify delirium in Parkinson's with a good degree of accuracy. And I'd like you to please keep in mind that hypoactive delirium may be present in people with Parkinson's. So keep this in mind when you're thinking of delirium diagnosis in people with Parkinson's. Finally, I'd just like to thank my collaborators who are listed here, our funders Parkinson's UK, Newcastle upon Tyne Hospitals for sponsoring the study, and the Brain and Movement Research Team, who I belong to and is led by Lynn Rochester, for their support. I'm very grateful to all of the participants and their relatives and carers for generously participating in the study and giving up their time, without whom this work would not be possible. Thank you all very much for listening. Please follow me on Twitter to keep up to date with our findings, or email me with any questions that you might have. And thank you very much.